Well, my friends, thank you everybody to be here. And now it's time to do some questions. Now, to answer some questions, we have here more than 10 questions. Let's try to respond to all of them. We have many congratulations to Dr. Diana Gaitini. Uh, Everybody liked your presentation. I'm the first. I'm the first fan. Fantastic presentation. Uh, there is a question for Dr. Gaitini regarding to the ankle brachial index in diabetic patients. We need to do that. It has value.
Yes, it has if they are symptomatic, and maybe the first screening examination to determine if there is a vascular disease. The problem with diabetic patients is that the disease is mostly peripheral in small arteries, and so the sensitivity and specificity may be lower with the ankle brachial index, because we are measuring the systolic pressure at larger arteries that may be still open, and the disease really is more peripherally in the very small arteries.
Yes, I agree with you. Sometimes if the artery is very high, is very rigid, so we can obtain those values 1.3 or more, and probably in just these specific cases, very high result. So you cannot determine is really it's an obstruction or it's a problem of itself of the artery wall. But in all of the cases, I agree with you, Diana. Absolutely, it's even the patient is diabetic, we have to do the ABI, the ankle brachial index. Okay, there is a question here. Clot inside the great saphenous vein. We prefer to call it magna saphenous vein. Can you use the term DVT? No, it's a superficial thrombosis, vein thrombosis, with an exception. If the thrombus is in the confluence, saphenous femoral confluence, and it reaches 2 centimeters, very close to the femoral, common femoral vein, for practical purpose, you can consider, or we can consider that as a DVT, and it's necessary anticoagulations. We have to report to the referral doctor that we have a thrombus in the confluence, but very close, less than 2 centimeters, because he will know that it's necessary to treat these patients with anticoagulants. But no, just in the magna saphenous vein is a superficial thrombosis in the rest of the vein. In the meantime, where I seeing the question, I have a question for Diana. Diana, in order to study the upper limb in occlusions of the thoracic outflow, do you perform provocative maneuvers during the ultrasound? I mean, move the ankle, the arm up and down, open 90 degrees. Do you, at the same time of the ultrasound, do you perform these maneuvers?
Yes, of course. Yes, okay. Because if you hyperextend the arm, you see how the flow changes. And you see exactly the increased pressure on the artery while the arm is hyperextended. So yes, we do the examination while hyperextending the arm.
Fantastic.
I have one question for you. This POCUS examination, do you propose to be done by the clinicians? Is
the actual
trend?
Okay. My answer is a big yes. This POCUS assessment is really oriented to the clinician, to the emergency doctor, to the vascular surgeon, to all these medical specialties that have the opportunity to receive the patient, see the patient, and with a conventional car-based ultrasound or with a portable or audible portable, the clinician performs the assessment and decide immediately there is a thrombus or there is not, or in the case of a trauma, abdominal trauma, perform the fast. So this focus is oriented to mainly to the clinicians. And after the diagnosis, okay, these patients can be oriented to the radiology department in order to do a CT scan or more in-depth ultrasound, but it's mainly for clinicians. There is a trend, international trend at this moment, and in some universities in Europe, uh, in Europe, in United States, and even in Latin America, are teaching POCUS for medical students, undergraduate students.
That's right.
Let's see what else. It's advisable to perform compression at the edge of the DVT. It's necessary to do the compression always. But as I mentioned, be gentle, okay? If you see something inside, you are seeing some echoes inside, uh, uh, do the compression. It's necessary. If you see that the walls decrease the diameter of the vein and you are seeing something inside, okay, it's not necessary to squeeze the vein, because in some cases, the thrombus can be fractured if you are not gentle, if you are very rude, I mentioned. Let's see what do we have. We need, let's see, question for Dr. Gaetini. It's a privilege to have her today. Well, I'm pleased to inform you that we have attendees from many countries and all the continents: Asia, Africa, Europe, Latin America. Okay, I have one here. Let me see. I have seen case. Uh, let's see. I have cases with dilated deep vein with significant slow venous flow. Should I comment is an impending thrombus? Okay. The slow flow is some kind of condition of precondition from thrombosis. It's not an organized thrombus. If we have a very recent thrombus in a way to the formation, it is heterogeneous, it is homogeneous, alternating areas with anechogenicity and some areas with echogenicity. But the impending thrombus has some limits, but the slow flow is more extensive. It takes all the vein. But we have to warn, to give the alert to the referral physician that in this case we have a slow flow, because we have to determine why this patient has a slow flow. If the slow flow is in one extremity, in one leg, we have to look for the higher level that we can do it, because the problem could be in the iliac vein, for example. In many situations, in many cases, we have seen bilateral slow flow, and then we interrogate more in depth the patient, and this patient can be, we have seen oncological patients in treatment for prostatic cancer, of ovarian cancer, uterus cancer, and in this case, the disease is compressing the cava vein. And this is the reason, because we have the slow flow with more symptoms, with edema. So there is attention if in one side and attention if bilateral. We have to pay attention in all in all the cases, because we try to find the answer of why this patient has a slow flow.
You had another question
Yeah.
about fresh to old thrombosis.
Okay. I show the slide. The recent thrombus can be anechogenic or hypoechogenic. Sometimes you don't see it, but when you start to do in the very recent, in the very fresh, you don't see it, but you see the dilatation of the vein, and the compressive maneuver is positive. You cannot compress the walls. With the evolution, some more echogenicity is in the thrombus, but always the recent has low echogenicity. And you have another signs. You have that it's a floating thrombus. It's the edge of are defined. The vein is painful also at the moment that you do the compression, but the old thrombus is heterogeneous. The echogenicity has variations inside the thrombus, and you have medium echogenicity, even points of higher echogenicity. The vein could be not dilated, but shrinks in these cases. The vein is not painful, and the thrombus is very sometimes very limited, depending on the extension of the condition at this moment, because the main edge that can be compromised is femoral popliteal, and then you can have an occlusion, total thrombosis from the inguinal area to the popliteal area. So depending also the extension, but it's necessary to see the echogenicity mainly. In peripheral artery disease, Diana, it's a regular first choice of approach of the patients. You mentioned because it's time consuming. In some centers, they decide to go directly to MRI or CT scan. But I think that in many centers, you have these two previous assessment, the ABI, ankle brachial index, and it's very easy if you have these kind of machines that represent where the Doppler signal get down. Now you know where you have to look for with your Doppler, but I have read some of your papers, Diana, that the recommendation is to use it as first choice. Can you explain us a little bit about when to perform the arterial Doppler in peripheral legs extremities?
Yeah, mostly it's a matter of experience and knowledge. There are some places that it is routinely done. The ABI test is almost always done. Is the first screening test. And if you have an abnormal test, you may go to an arterial Doppler examination to examine those places where there are aliasing, areas of stenosis, or even obstruction. So to do a more detailed examination. Sometimes it is so time consuming that some places prefer to go directly to CTA. Even us, in many cases, we go to a CTA, is what the vascular surgeon asks for. It's not only our decision.
In our center, we perform the arterial Doppler in both legs, from proximal to distal. And we study all the legs, even with the ABI normal, because, well, the referral doctor is requesting all the study, so we don't stop it. But for example, allow me to make this comment. For example, in Australia, it's very the appointments, you have to wait a lot of time for an appointment in most of the cases for having a Doppler, arterial Doppler, and they are not the only ones that do that. They start distal, and they checked the tibials, anterior and posterior. If the pattern is triphasic, they stop. They said stop. It's triphasic. So upward, upstream, there is mild disease or no disease, and they stop it. Triphasic, okay, you are okay. And next, if somebody has monophasic or biphasic, so they start to go point by point until find the lesion. So it will depend on the country. It will depend of the guidelines or rules in your specific lab, university, depend if you are in a private medicine or you are in a hospital. But we prefer to do both legs, and we start proximal to distal. And yes, and
Because
then we go to
in many cases,
continuation.
it's a matter of the development of collateral arteries. So
Mhm.
maybe there is a high stenosis, but good collaterals,
Mhm.
and the flow turns to be normal distally.
Fantastic. Well, my friends, well, our special invited speaker, thank you so much for being here in this vascular webinar organized by the Education Committee of WFUMB. I really thank you all for being here, and we will see you in a coming webinar. We have different types, different topics, with always very special invited speaker as today. Gracias, Diana. Muchas gracias.
Thank you.
Okay. Goodbye, everybody.
Bye bye.